And as soon as I pulled the trigger, like a lot of them changed.
Why?
And
Did they think you wanted to steal their husband?
I mean, if you saw them,
You're like,
if you saw their husbands, like,
no. Sorry. But why do you think it changes?
So I think some of it is that I think some women are just worried, like, now you're this like free and loose woman, you're going to come after their man.
So lucky to get off your hands. Anyway, we'll move on.
But I think some of it is also you've done something that maybe they don't have the guts to do.
Like you're holding a mirror up to them or something?
You're kind of holding a mirror up. You're like, you know what?
Welcome everybody. I am here with the delightful Dr. Rebecca O'Dwyer, who is an assistant professor of neurology. Oh my goodness, that just sounds so intelligent. It's like, I feel a little bit thick sometimes sitting in this chair opposite people like you. Assistant professor of neurology, specialising in epilepsy.
Yep.
And one would have thought that it's not a terribly interesting topic, but judging from the amount of questions that I got in the space of 2 hours before we came up to this podcast, it's actually of extreme interest to people, whether or not they suffer from it, whether their family members suffer from it, or whether they just want a little bit of advice about it. So let's just get straight in there. What is epilepsy?
So epilepsy, obviously it's a neurologic disorder, and really what happens is a group of neurons in the brain start firing in sync. And that's not how your neurons, your brain cells should actually fire. Usually they fire out of sync. And so we call it in fancy terms like aberrant neuronal firing. And what happens is one area, usually it's one area of the brain starts firing away in sync, and it spreads throughout the brain. And then you see the outside, you see people convulsing.
Okay. And that can be a very scary experience for someone that's watching that.
Yes. I think, I mean, I've seen so many seizures now. For me, it's not scary, but I remember as being a trainee, and that especially like loved ones of people with epilepsy, for them, most seizures end under 5 minutes. But for them, those 5 minutes can feel like 5 hours when you're watching your loved one, convulsing away, shaking, and not there, completely out of control.
And the way we always hear about, if someone's epileptic, they can swallow their tongue, or, don't put your hand in their mouth.
Yes.
So what is this thing about swallowing their tongue that everyone's so scared of?
So it actually doesn't happen.
Okay.
What really happens more often is people actually bite their tongue during a seizure. So absolutely don't put anything in an epileptic's mouth when they're seizing, because they could actually just bite your fingers off, because they have no control of what's happening with their body at that time.
Okay. And are they totally unaware of what's happening?
Yes, they are. So sometimes at the beginning of a seizure, they have what they call an aura. And an aura is the first manifestation of the epileptic activity. Some people have like this rising sensation from their belly. Some people smell like a really nasty smell. It tends to be burnt cigarettes. Some people get numbness and tingling on one part of their body. And they're usually aware for that. And that lasts normally about 30 seconds. And then they usually, as that epileptic activity spreads through the brain, then they lose awareness. And that's when you see kind of the convulsion, what everybody thinks of as a seizure. Okay.
And does it cause memory loss at all? Or does it affect the brain in any way? Does it cause damage when people are having seizures?
Yes. So when a patient has like a big seizure where they do end up convulsing, often they lose memory, a little bit of memory from the time before. Not all the time, but sometimes. And we know that uncontrolled seizures over years can lead to memory loss.
Okay.
Yeah.
And can it lead to brain damage?
It can. So we can see on MRI scans, and we can see parts of the brain. So the one particular part of the brain that I'm thinking about is the hippocampus. So if you were to draw a line through your eye and through your ear where they meet, there's two structures on either side called the hippocampus. And that's where we make memory. That's where we consolidate our memories. And that's a very pro-epileptic part of the brain. So seizures like to propagate through it. And so we can see when we look at an MRI of somebody who's had seizures for years, we can actually see it being sclerosed or kind of being scarred down from the epileptic activity over the years.
Okay. So are people predisposed to epilepsy? Does it run in families, or how does it work?
It can run in families. We know there are some genetic mutations. So a lot of the early childhood epilepsies are because of genetic mutations that we know about. But also traumatic brain injury. Okay. That's a risk factor for developing epilepsy. People with dementias, so about 10 to 15% of people with Alzheimer's disease will develop seizures. 3% of people with Parkinson's disease will also develop seizures. Tumors, brain tumors, often the first sign of a brain tumor is somebody out of the blue who's never had epilepsy will have a seizure, and then you get the brain scan and then you find the tumor.
Okay.
Or people post-stroke.
Okay, and how does the brain bleed cause it?
So what happens is, you have this bleed and you have these blood products kind of sitting on your brain, on the brain cells. And as your body breaks it down, the iron in your blood is very irritable to brain cells. And so that's what kind of irritates them and gets them firing when they shouldn't be firing.
Okay. So, and then, you know the difference between a febrile convulsion and epilepsy?
Yes.
Is there a difference there?
There is. So febrile seizures usually happen in young children, and it's usually in the setting of a very high fever. They have a convulsion, and usually that's it. You should still always go to your pediatrician and tell your pediatrician about the convulsion.
So for people in Ireland, that means just going to the Children's Hospital.
Yeah, sorry.
Becky has been in America for way too long. We don't have paediatricians over here unless there's something seriously wrong with us.
Sorry. Oh, man. And then so later in life, they might go on. They're more likely to develop seizures. Now, I don't want people panicking if their child.
That's not what we want to do.
Right, we don't want people to panic. It's not a foregone conclusion that your child is going to go on and have epilepsy. But it is one of the questions. So when I get a new patient, it is one of the questions I ask them, did your mom ever tell you as an infant you had a convulsion? That's always one of my questions.
Okay. And then do you look after children or adults?
Adults.
Okay, so from what, 12?
12 and up.
Okay.
Yeah.
Okay.
And then I have a little niche of epilepsy in the elderly as well. That's why I was here.
Okay, so why were you here? Tell me.
I
thought you just came over to see me.
Well, it was primarily for you. I had to find an excuse to come over. I was chairing a session on epilepsy in the elderly at the International Epilepsy Congress.
Okay, and is that because epilepsy can increase? Well, obviously you said with Parkinson's and dementia, which are diseases generally of the elderly.
Yeah.
So you see it more and more. And why is that a little niche of yours? Why do you like it?
Well, I like old people. I love chatting to old people and hearing their stories. So actually we think of epilepsy as a disease of youth, right? Even neurologists, but actually when you look at what we call the incidence, so when people first get diagnosed with epilepsy, there's it's around birth. And that's because of, traumatic births, in utero strokes, things like that. And then the childhood epilepsies. And then there's a little blip around 15 to 25. And that's usually when people, they start drinking excessively, maybe. Not that we ever did that.
Wouldn't know anything about that.
Going to discos, going to the clubs with the flashing lights and staying up all night. So those are all three things that will lower your seizure threshold. So you often see a blip, kind of like I said, 15 to 25.
Okay. Not that those things are causing epilepsy, but just that if you're predisposed, you're more likely to have it instant.
Exactly.
Why do the flashing lights cause it?
So there's some types of epilepsies that we call... what do we call them? They're photosensitive epilepsies. And there's something about it triggers. There's some genetic mutations associated with it.
Okay.
Yeah. And then there's kind of a dip in kind of newly diagnosed epilepsy. But then from about the age of 55, there's a very steep uptick. And again, it's people start having strokes, people develop brain tumors, they maybe have multiple traumatic brain injuries, and then they develop dementias.
Okay. So what percentage of people, say, have epilepsy?
It's about 1% of the population.
And is that then increasing as we... as we have an aging population?
That's a really good question. I don't know. That's a really good question.
Okay.
I think we are now becoming more aware of epilepsy in the elderly because the seizures that you see in the elderly are much more subtle. And they're not these big convulsions, so it often goes unmissed, or goes missed, I should say.
Is that what an absence is?
It can look like an absence seizure, yes. But
So
absence is, not to get all technical and boring.
No, I think so. Do you know what? I think this is interesting. We'll kind of like do like it's like a high level spin of the different types. Yeah.
Right. Yeah.
Okay.
So absence is like when people kind of stare off, right? And technically, absence is when you do the EEG, the brainwave test. We see a particular rhythm throughout the entire brain. But other types of epilepsy can also manifest as staring off. And so it's it's very frequent, like especially in the elderly, or you'll see somebody that's just like, which is, just like mouthing.
Okay.
And that's a very common kind of early manifestation in a seizure of seizure activity.
Okay.
And there's all sorts of things. So epileptologists, we're pretty good actors. So we'll often in the
I
clinic.
just love the way you did that. You look like you were breastfeeding there.
But we'll like act out things in the clinic room and ask family members, like, did they do this? Did they do that? Because by telling us that information, then we can tell where in the brain the seizure is coming from. And that helps us treat it.
So the different seizures types, or the different epileptic types, start at in different areas in the brain.
Yes. Yeah. Yeah.
My goodness.
And that then helps, like, depending on where it starts, will inform me which medication I'm going to give you.
Okay.
Yeah.
So explain are there other 4 main types of epilepsy, or 3 main types, or is there like 10 million? And
no,
we'd be here all day?
we'd be here all day.
Okay.
We'd be here. It'll be boring.
Okay.
I don't want to bore everyone.
Okay. So do you operate on brains then?
No, I don't operate on brains. I tell the surgeons where to operate though, so that's kind of nice.
So how does it work?
So in America, usually what happens is somebody develops epilepsy, develops seizures, and they go see a general neurologist. And then if the general neurologist can't get their seizures under control, they send them to me.
Okay.
And I should say about 2/3 of people with epilepsy will be controlled on one anti-seizure medication.
Okay.
And then when you add a second, another 5% will be controlled on meds.
And that's
good.
their general neurologist does that?
Yes.
And then they go see you because you're like expert in difficult cases?
In difficult cases, yeah.
Okay.
So that's all I see.
Okay.
All day, every day are people with epilepsy.
Okay. And you're obviously in a university hospital, teaching hospital
I
then
am.
too, yeah?
Yes, I am. Yeah.
Okay.
And so then I'll meet them, and maybe sometimes I don't agree with the med choices that the general neurologist made, and I might try to tweak them and see if I can get the patient seizure free. And then if not, the next thing is to do an EEG and an MRI usually.
Explain what an EEG is.
So an EEG is an electroencephalogram. So what we do is we put these little metal caps on the scalp of the patient, and then they just chill out for somewhere between 20 minutes and 2 hours, and we measure their brain waves. So we actually see their brain waves, and we can see epileptic activity. Even without them actually having a seizure, we can sometimes see epileptic activity.
Okay. Do you have to shave their heads to do that?
No.
Okay.
No. Now it's stinky, and they usually have to like wash their hair afterwards. Like the stuff we use is pretty nasty, but we don't have to shave their heads. So what happens then is we actually what we do is we have an epilepsy monitoring unit. So we actually bring them into the hospital for somewhere between a day to 5 days. And we might take them off their seizure meds, sleep deprive them. We don't give them alcohol, and try to provoke a seizure to see if we can find out on the EEG where exactly the seizures are coming from.
Okay.
And then we'll get an MRI as well. Sometimes they have like something on their MRI, so some damage that would point to where the seizures are coming from. And so if The EEG is pointing to the same area and the MRI shows the same area, and it's not what we call eloquent cortex. So eloquent cortex is basically cortex that if we cut it out, you would miss it, right? So, motor, like moving, sensation. And so if it's not eloquent cortex and we think we've got a good shot, then we'll actually go to the surgeon and we'll ask them to take it out.
Okay. But is there a risk that, well, there's always a risk, but can you cut out a little bit of brain and it'll only help with the epilepsy and not have any other damage? Or is there always some kind of damage to some other part of the body?
No, for the most part, no. Right. So, the most common surgery that we do is a temporal lobectomy. So your temporal lobes, again, you've got two of all of these. They're like the areas behind your ears. And that's where this structure that we were talking about, the hippocampus, is. And so people with temporal lobe epilepsy, that's the most common epilepsy surgery. We'll take that out. Sometimes, depending on which temporal lobe that is, they might have a little bit of verbal memory problems afterwards. But here's the thing. If you're seizing repetitively, your seizures are going to damage your brain. You're going to lose that memory anyway. It's just going to take a little bit longer. So a lot of patients, and it's not like they can't remember. They have like word finding difficulties, right? They're not getting lost. They don't forget birthdays.
Okay.
I did have one patient though, actually feign memory loss after a seizure. He said he didn't remember his girlfriend.
Did it really?
He really did.
And how do you know that they're taking the absolute mick?
Because that just wouldn't happen. I mean, that amount of memory loss, that just would not happen.
Okay. And then, is it a case where someone can have mild epilepsy and someone can have severe epilepsy?
Yes.
Okay.
Yeah.
And would mild epilepsy then, if they're having a seizure every 2 years, would you consider, what's the point in putting them on medication that, has side effects and stuff if they're only having one seizure every couple of years?
So I would still put them on medication because, I try to explain epilepsy or epileptic activity, right, so if you're boiling a pot of water on the stove, right, you turn on the heat and it starts heating up. And on the outside, you see nothing happening, right? But if you look into the pot, you see the little bubbles. And those little bubbles are like what we call interictal activity, or just the epileptic activity that we maybe see on the EEG, but we don't see anything on the outside. And we do know from animal models and just from treating people with epilepsy that seizures beget seizures. So the more you let those bubbles, keep bubbling, eventually, just like that pot of water, right, enough of them will come together and they'll boil over. And that's like a seizure. Okay. And so one of the devices that we now have, so sometimes surgery isn't for everybody and we have other options now. And I remember I was a fellow at the time when they were doing this study where they actually implanted EEG leads into patients' brains and then measured their brain waves 24/7, but actually in their brains. And it was shocking. We actually realized that people were having tiny seizures much more often. And we had no idea that was happening because on the outside, we didn't see anything happening.
Okay.
So if you have epilepsy, you probably should be, even if it's only every 2 years, you don't know what your brain is doing kind of in the background.
Okay.
Does that make any sense?
Oh, no, it absolutely does. Is epilepsy linked with autism or ADHD or learning difficulties? I'm getting those kinds of questions in.
So there is, it's definitely seen more frequently with people who have ADD, who have autism. It's so funny, there was a whole lecture on ADD and epilepsy. There are some genetic mutations that have been associated with, like, people are starting to study that now more and more.
Okay.
I think the one kind of other, I would say, the other disease state that we see frequently are depression and anxiety.
Okay.
Right.
And why is that?
So we don't understand, again, there's some genetics behind it, but there definitely is a bi-directional relationship between depression and anxiety and seizures. And it's more than just, I'm depressed because I'm having lots of seizures, right? Sometimes people will be depressed and then develop seizures. Sometimes it happens the other way, right? Mm-hmm. And we know that if we help control the depression, we can help control the seizures as well.
Okay, but is that just because depression obviously is in the brain, anxiety is in the brain, so is epilepsy, and the brain's only so big, so things are going to be there's going to be comorbidities.
There's going to be comorbid, absolutely.
So if one part of the brain is affected, like the hippocampus,
right? Well, if you think about it, again, not to get too technical, but our limbic system in the brain, which also helps control our emotions, the hippocampus is part of that, right? So it all makes sense, right?
Okay.
But it's something that you have to, like as an epileptologist, all my patients, we do a depression and an anxiety screening, every time they come and see me. And I probably just as often prescribe antidepressants as I do.
You just answered my question. I was going to say, do you prescribe it for them, or do you send them to a psychiatrist? But
no. So I have a comfort level, and if I can get it under control, and then after my comfort level, then I would send them to a psychiatrist.
Okay.
Yeah.
So what got you in? Sorry, one question before we move on to this. You said that you were a fellow. Can you explain to people what a fellow means?
So in America, you get your medical degree, and then you're an intern, and then you're a resident. And an intern, you either do a year of internal medicine or you do a year of surgery. And then when you're a resident, that's when you choose your specialty. And so that's when you do your specialty training. So I did mine in neurology. And then after you have your specialty training, you have to do some exams to get a board certification if you want to get a job. But you can decide that you want to subspecialize, and then you become a fellow. And so I subspecialized in epilepsy.
Okay.
Yeah.
And how did your interest in epilepsy come about? And I have to ask you, Rebecca, was it anything to do with the fact that we studied Silas Marner for our junior cert? Oh my God, do you remember that book?
Oh my God.
Just to let everyone know, Becky and I went to school together, and we both studied Silas Marner, which is the most boring feckin' book going. But
torture.
If anyone did that for their junior cert, they'll know Silas had epilepsy.
Yes, he did.
So was it anything to do with that?
No, it wasn't.
I can't imagine that it was. I'd be bitterly disappointed if it was. So how did you get into epilepsy and your interest into it?
I actually studied medicine in Germany. And so the German system is you do 6 years of your degree and you get your medical degree. But if you want to get the title MD, medical doctor, you have to do some research and then write up a thesis and defend it. And you do that. It also helps you just stay in academia if you do that. So when I was in my 4th semester, I think it was, I was looking for some thesis work to do, and I actually ended up studying particular head movements. This is where getting back to where great actors acting out seizures. I studied versive head movements in temporal lobe epilepsy. And my mentor, he was just great. He just really got me into it. I used to work part-time as an EEG tech. I'd do a night shift and read the EEG, and that just got me into epilepsy.
Okay.
Yeah.
And you're one of these mad jokes. So Becky imagine going to Germany to study medicine, the fucking torture of that. And you weren't even fluent in German.
No.
So how did you come about going there? So tell us, because you did science.
I did 2
years
of science at Trinity, and a friend of mine who was German was like, oh, you should just apply at Germany, because I didn't get the points to do it in Ireland.
Isn't that a great story though? Look at you. You didn't get the points. You didn't get the points in Ireland. You went to Germany, and look at the career path you've had. Yeah. So and sometimes it's great to just do something that's different.
Yeah, no, absolutely. I don't think I would have had the career that I have now if I had stayed in Ireland. I mean, I don't know that, right? Yeah. But definitely, Yeah, it was great. I mean, I had Leaving Cert Irish, like Frau Sullivan would be very proud.
Oh.
But I do remember. So I had done 2 years of science. So I had basically done most of the preclinical work. There were a few other classes. So I went to Germany. I did all the same classes again, but I knew the content because I'd already done it in Trinity, and just kind of immersed myself and tried to learn the language. And so that by the time I got to the clinical years, I was fluent enough anyway. So
that's some going, isn't it? That's like drive, isn't it though?
Yes.
Oh, I'll just go to Germany, learn German, do a medical degree through German, do my all the rest. And then, so what brought you to America then?
So my mentor, with the epilepsy, he sent me to the Cleveland Clinic as a student to get more patients for this study. So I went over as a student. I actually did their fellow EEG course and they liked me. So when I graduated, they offered me a job to be a fellow at the Cleveland Clinic. So then I just packed up my stuff again and moved across to America.
And so it is, and that's how it worked out.
That's how it worked out.
Can we talk a little bit about how the medical system works over in the States? Because I know that it's very different over here. Because even you were like, yeah, just go to your pediatrician, and your local neurologist will look after it, and then if they can't sort you out, come to me. Like literally here, it's like you go to your GP and you get referred to a consultant, and that's kind of it,
right?
You know?
Yeah.
So, but also America is a very different system in terms of how they look after people.
Yeah.
And there's a lot of money in healthcare.
Yeah.
And people that are poor tend to not get looked after. So how does the whole insurance thing work over there in terms of if someone needs to come to see you?
So most people in America, they get their health insurance from their employer. So part of having a job in America is that it comes with benefits. So it comes basically with health insurance. And so when you have health insurance, and I was just thinking about this today as I got a bill for a test that I got done myself, so when I, as a doctor, so when I join a practice or I join a hospital, they credential me, right? So they make sure I'm the real thing, right? And then they put me up for, I think they're called panels of insurance companies, right? And so, an insurance company will have like a list of a neurologist that they cover, whose services they cover, right? Okay. So as a patient, even if you have health insurance, you have to check with your health insurance company that the doctor that you're going to is covered by their plan. Because if not, you have to pay out of pocket, which is kind of crazy. And so basically, if you're employed, you'll have health insurance through your company. If you're not employed, you're kind of on your own. So they have what they call Medicare, and they've Medicaid. So Medicaid is for people who are, I think, along the poverty line, or they're a little bit above the American poverty line. And so they will get their health care covered by the state. And then people age 65 and older get Medicare. And they get most of their health care covered. But there's all these co-pays and deductibles, right? So even when you have health insurance or you have Medicare, you go to a doctor, they're covered under the plan that you have. You might have to pay like $20 or something, or $30, right? Okay. And then some plans will say, well, you have to put down, in 12 months, you have to put down $5,000 and then we'll start paying. So there's all these like different plans and things. It's very, very complicated.
It's an absolute business though, isn't it?
Oh, it's a business.
And
it's
people
an absolute business.
Are stuck in jobs because the jobs pay their healthcare and they absolutely hate their jobs, but they can't get out. So, and it must be difficult for people that are self-employed over there, unless you're making
very difficult. So I want to say, and I don't know the ins and outs of this, I think like with Obamacare, the American Medical Act, I think they made some they tried to make some advancements for self-employed people, but it's a big problem. And then you've just uninsured, no Medicaid, and those people usually what happens is they don't go to the doctor, so they don't get kind of the timely care they need until there's an absolute emergency or disaster. And then they usually end up in, most larger cities have like a city hospital that kind of will give you the health care that you absolutely need, right? But maybe not everything you need.
So they kind of like
sense?
patch you up and send you off, but you could like still be.
And I will say, and I, like if any of my colleagues in the States, I don't want to annoy them, because I have some colleagues who work in those hospitals, and really they are giving, like they do all they can for their patients, right? But it's not a good system. It's
prohibitive because they can't do what they really want to do for.
Exactly.
But even you were saying to me, because Becky and I had to have a little chat before we did this, because we have so much to talk about. Like you were saying to me, you have had patients come to you and they're under a certain plan, and you may have had their seizures under control with a particular drug.
Yeah. And then their insurance won't cover the drug. So I remember this one young woman, bagged epilepsy. We finally got it under control. And she was she was seizing like once a week, and we had her like 3 months seizure free. And she came into my office crying. She's like, "You have to take me off that medication. It's costing me $2,000 a month, and I can't afford it." And
that's crazy.
It's insane. And
see, that doesn't happen here.
Yeah, no, like that's heartbreaking.
Yeah.
Like, to know that you could be seizure free, but you can't afford it. That's just wrong. That's wrong.
And then even with having babies over there. So, you know, I've heard some stories and stuff, and I've seen like a hospital bill from someone who was in having a baby, like 40 grand or something ridiculous. Okay.
No.
So like you'd nearly go and have it in your own home because you can't afford that. It bankrupts you.
Right.
But then also like people being given paracetamol, you know, 4 times a day after they've had a baby, and it's like $250 for each paracetamol tablet or each time they've been given it. Why is it so ridiculous?
I think it's honestly, it's a business, right? I think the insurance companies are like, they're making record profits, right? And the humanity in the system is kind of gone, right?
Okay.
I think, you know, so like I'm an academic neurologist or an academic epileptologist. And so I stayed in academia so that I wouldn't be put under those kinds of market pressures.
Yeah.
So like one of my best friends from residency is in private practice, and she goes through patients. She sees like 18, 20 patients a day, very, very quickly. And, you know, and she has to do that so that her practice will make a profit so that they can stay afloat. And so, you know, somebody like me, I get a little bit more time with my patients. And I always thought it was, you know, I wouldn't be put under those market pressures, but more and more now.
Okay. And sorry, why is that? So you, and you're put under pressure to see more patients because you can charge the insurance company that then pays the hospital.
Right, exactly.
So how do the insurance company make a profit when they're putting so much money out for these treatments?
Because of the premiums that people are paying.
Okay.
And I mean, they obviously, they're way smarter than I am. Like, they've done the math. They've figured out they're never going to lose.
Okay.
Right. So, it's insane.
And do medics just accept this then? Is it just there's no way to change it? It's almost like how money rules and that's it. Like, you can't even, like, there's no disruption in the system because, you know.
No.
As a doctor, I can imagine that, like, that girl that came to you that couldn't afford it. Like, I mean,
no, that's awful, right? That's awful.
Yeah.
And I think people, I mean, that's the like Americans, they're just very different. So for them, right? So I feel like in Ireland, like, healthcare, education, those are just like basic human rights, right? They're not in America. They're not, right? And so the Americans' outlook on life is very, very different. So they just kind of take it.
Yeah.
There's another system within the States, the Veterans Administration. So what, like the VA, the infamous VA. And so that's for people who've served in the armed forces. And that's the closest thing America has to kind of a universal healthcare system, right? So they automatically get their healthcare. And they have specialists, right? They don't have all the bells and bows maybe that, say, my hospital would have, like an academic hospital would have, but they're very good, right?
Okay.
And ironically, you know, and I'm going to say this with all respect to those patients, right? But they're not necessarily the healthiest. They're like hard living. Usually, most of them are men, hard living, hard drinking, hard smoking, right? Men. Yeah. So not your uber healthy demographic. And time again, health outcomes at the VA beat private insurers.
Okay.
And I think some of that's just going to the doctor regularly, right? You can. You know, I tell my trainees when they're choosing a residency, so when they're choosing somewhere to do their training, I always tell them, make sure that your training program has an academic hospital, a VA, and then one of those city hospitals that I was talking about for like the uninsured, because the same diseases, everybody gets sick, but they present completely differently in these different populations because of access and lack of access to regular medical care.
It's
crazy. It's crazy.
But you've had your own taste of that.
Yes.
With, well, not just your little result that came out today, but you had a premature baby.
That's right, I did. So in actually the very beginning of my I guess it was my second year of neurology training, so it was my third year. I was put on bed rest at 20 weeks. I had cervical insufficiency, and then I gave birth at 23 weeks and 4 days. So that was crazy. And I remember. Did
you have a cesarean or did you give birth vaginally?
No, I gave vaginally.
He came out quickly, did he?
Well, so that was a whole like. Do we do a C-section? Do we not? And against my obstetrician's advice, I wanted a C-section because I thought it would be a quicker birth. Because you know I'm an epileptologist. I'm like, I don't want them to have a stroke. But he was actually breech.
Okay.
So he came feet first. He literally kicked his way out.
Oh my goodness. But probably so small that it wasn't.
Yeah, no, it wasn't. No, he was 1 pound 6 ounces.
Oh my goodness. So that being said, right?
Yeah.
What were the options for you with your insurance and your baby? Because it was someone told you to go.
That's right. So we had good insurance, right? And a social worker kind of came to us. I don't know. He was like maybe 2 or 3 days old. So it was like day by day, was he going to survive? And she was like, I know you don't want to think about this, but you really should apply for Medicare for him. So this is this state-run program for people age 65 and older. And then it's also for people with disabilities, and there's certain little populations that it serves. And one of them is children who have a birth weight under, I think it's like 3.5 pounds or something. Anyway, he was very little. He more than covered it. And we had 30 days to apply for that. And I remember saying, oh, it's okay. We've got insurance. We'll be fine. And she's like, no, you have no. Like if he survives, you have no idea how much this is going to cost. You need Medicare. And so I did apply for Medicare and he had it. And so you get the insurance or the hospital will send you a copy of the bill that they sent to the insurance company. And I think he was in hospital for 5 months and it was like, I think 1.25 million.
Okay.
Yeah, it was.
And what would have happened if you hadn't gone the Medicare route?
So I don't know for sure, right? Because I don't know exactly the ins and outs of the plan, but we probably would have been bankrupted. We probably would have had to have covered, because sometimes, so that's the other thing, you have to look at your plan. You might have a 5,000 deductible that you have to, cough up first within the 12 months, but then they pay everything. There's a lot of plans that maybe don't have that, but then they cap at a certain amount and then everything else. Right? It's
but then
so
just
tricky.
Say, like people that have, like they don't have insurance and they go to have a baby and it's a normal delivery and all that. Yeah. Is it still really expensive? Do these people still end up with like you hear?
You do. I mean, they do, and it's still super expensive. Yeah.
To someone living here, or even in Germany, I'm sure, because the European model is different.
It's different.
It just seems crazy, doesn't it?
Well, I think we consider it a right, just a basic right. They don't. It's crazy.
And then poor health outcomes just perpetuate then over the years. So you have a baby that's born, and it's not under great circumstances, and then the health outcomes for that baby, if mum can't afford to go to the hospital or go to the doctor, it's just and then you just. you
No,
know.
it just self-perpetuates
Yeah.
itself. It does. It really, really does. It's not a good system. It's really not a good system.
And then how much maternity leave did you get? I know the answer to this, but I'm just prompting her because it's bloody awful. I swear. We think we've a bad over here, which we don't, I don't think now. But tell us.
You get 6 weeks, what they call FMLA, family medical leave absence or something. So that's 6 weeks. And then anything else you take off, it's really up to you to foot the bill, right? Like you don't get paid and you have to negotiate with your employer.
Are employers generally nice? Like
No.
Okay.
I mean, look, in my job, I was fine. So like for my second, I took an additional 6 weeks. Like it was fine, right? But like there's women, if you're flipping burgers in McDonald's, right? They might want you back in 2 weeks, right? I mean, they're not allowed to do that. There's a federal law. You have to get 6, right? But there might not be a job for you afterwards. Like there's a lot of...
You went back to work after 2 weeks after your baby, though.
I did. So my first little guy, I did. I went back after 2 weeks.
But what was that like? For you?
I mean, I think I was just going crazy sitting by the incubator for the first 2 weeks. And I was lucky. I was actually luckier than most mums in that NICU because I worked in that hospital. So I would, and I talked to my program director, so kind of my boss of my residency, and he let me skip the lecture so I could go be with him. So I'd go visit him, then I'd go do my rounds. Lunch break, I'd go visit him again, go do my rounds. And then afterwards, like I just kind of lived in the hospital.
And how is breastfeeding over there then? If women literally have to go back to work within 6 weeks, breastfeeding is a tricky business in the first instance,
right.
Never mind if you have to go back to work.
Yeah.
How does it done?
You pump. Everyone has a pump. So they have federally mandated pumping rooms.
Are they really plush and luxurious?
God, no. They're usually like a repurposed cupboard, honestly. I mean, and they're getting better, but it's not. But I do love, at least in the ones that I have been, in the hospitals that I've worked at, there is an old Malgi chair where you can, pump, but there's always a computer, so you can pump and do your work. It's
oh wow, great. Like how can so I know from my pumping days, the milk wouldn't come out of the pump unless I was watching, listen to this, women giving birth.
No.
Yeah, I had to watch 40 one born every minute or something while I was pumping to get my, I don't know, it's getting your hormones
your hormones, your oxytocin
or else I had
whatever,
to be, they say think of your baby, but even if I thought of my baby, it wouldn't come. So I had to watch those, and that would get it pumping.
And that would get it pumping.
But so how, and so I can't even understand. Now maybe the pumps are better. I was using an L1 that I had to literally like maneuver my boob into. And
they were not like.
So they weren't brilliant.
They weren't brilliant, and it's just
you only get like a teeny bit out compared to what your baby can get out.
Yeah, no, this is true. And then you're sore. You're never. Yeah,
your nipples are literally stretched.
Yeah, no, it is. It's awful, and it's exhausting, and even just finding the time, right? Like I had to, time my day. So, I'm maybe not a very good negotiator. I know some of my colleagues were able to negotiate like a 15-minute pump break in their clinic. I didn't do that. So I'd pump a little before my clinic, and then at my lunch break, I'd try to pump a lot. Like
I've talked to doctors who have had the pump on while they've been dealing with patients. And one of them said she was seeing to a patient, and the patient's like, what's that noise? She goes, oh, it's my breast pump. And the patient was disgusted, so she said she never did it again because the patient reacted so badly. I know.
We're just people. We're people.
I know.
Like we have,
And we're called mammals because literally we've mammary glands to feed our babies. But anyway, that's an aside.
But no,
Christ, it's difficult, isn't it?
Like what women are expected to do. I mean, I remember with my second, and I was pumping, and and that's the thing, like I didn't want to give up those like in the middle of the night feeds, because that's when he like you said, like they get so much more milk, right? And I remember coming back, I was on in the hospital, and I was walking back, and I had seen, 10 patients in their epilepsy monitoring unit. And it's not a long walk. It's maybe like a 5-minute walk. But in those 5 minutes, I had completely forgotten who the patients were, what was wrong with them. And I remember going to a female colleague and just like crying and being like, I think I've got early onset dementia. And she like laughed at me and she was like, no, Becky, you haven't slept in over 9 months. Like you just need a night's sleep, and you're pumping and you're working and you're doing it all.
So being a woman in America kind of sucks.
It sucks. Yeah, it sucks.
So it's not, they say they're so progressive and they're so this, they're not.
No, they're not. They're not at all. I mean, just on Friday in clinic, I had an older man ask me if I was even a doctor.
Is that because you're 5 foot nothing?
Maybe. I mean, my Botox lady would be happy with that comment, right? Like I don't look old enough.
Well, that actually brings me on nicely to misogyny, and have you experienced a lot of that?
Yeah. Okay. I mean, I think that's just, I don't know, that's just part of it, right? There's definitely, I think. It's funny. Patients will say the most awful things to you, especially if you give them news that they don't want to hear.
Oh, really?
Right? Oh, yeah. Like
give me an example.
So again, this was in the.
I'd give them even worse news then if they're rude to me. Go, well, actually, you don't stand a chance.
Oh yeah, no, I remember.
This is terminal epilepsy.
This is terminal epilepsy. You're going to die. No. Yeah, I remember. Actually, it was funny. I had a female fellow. I had a female resident, and it was a woman. It was a woman in her, I think, 50s, and we basically told her that her seizures were not epileptic. So that's a whole other thing, right? But this is actually good news, right? You don't want epilepsy, but she was not accepting of the diagnosis, and she's like, "Well, you gals would do better in a nail salon."
What did you say to that? Just laugh?
I laughed, and then I'm like, okay, well then you'll have no problem with me discharging you. You can do the discharge paperwork now. And I turned on my heels and laughed.
I like it, sass.
Yeah, I'm sassy. I give it to them.
And in terms of other colleagues, did you find what are males like and females like to work with? Is there an undertone of just women not helping each other?
There is. There yes and no, okay. Right? I think yes and no. Like if I'm very honest, some of the people who've maybe thrown the most stones in my career path have unfortunately been women, and it's usually jealousy, right? Okay. But I've also had fantastic mentors that actually for the most part have been male, right? Okay. I think America at the moment is kind of coming to a reckoning with the white male, right? So you see it especially in medicine, right? White males have had it so good for so long. And I think they walk through completely unaware of how good they've had it for so long as well.
So blissfully ignorant to the fact that everyone else is struggling a little bit more than they are.
Yeah, like I have a again, he's a white male. He's a very close colleague, a good friend of mine actually. And we were talking about one of our trainees. We're actually talking about 2 of them. And one was male, kind of a little overconfident, too confident, right? And he was kind of saying, I wish this one didn't have as much confidence, and that this other young lady, another resident at the same level, was a little bit more confident. And he was like, she's so good. And I was like, yeah, she's excellent. And I said, but she's 6'2" and she's got a bigger build. I said, if she comes into a room confident, people are going to call her aggressive. And he looked at me. And I'm like, you're just a white male. Like, you're oblivious to this. And I did. And I said to him, I said, I come into the room and I said, I can come in confident and people ignore me. If I come into a room and I give a bit of sass, then, she's that little feisty Irish lady. And that's more acceptable than a confident 6'2" woman.
It's crazy, isn't it?
Yeah.
Tell us about... Tell us about when you were you were an intern and you were there's a guy doing surgery, brain surgery or something.
Oh my gosh, yes, yes. So this was one of the ORs or operating theaters that I was in. It was an epilepsy surgery, and I was very young at the time, and that's like when you're not a surgeon, like I'm never at home
Okay.
in the theater. So I'm always afraid I'm going to hit on something and then everything's, they're going to have to redo everything and break sterility. Anyway, this was the first time I had been going there with a colleague had been accompanying me, just showing me the ropes. And anyway, so this was the first time I was on my own. And the surgeon had his back to me. He was, putzing around in the brain. And she's like, "What's your name?" And I was like, "Becky, sir." And he's like, "Huh, yeah. How's your sex life, Becky?" And this was in front of the entire operating theatre, right? Like the anesthesiologist, the nurses. He had a fellow with him. And I kind of, took a deep breath and I said, "Well, Dr. So-and-so, if you're asking, it must be better than yours." And he stopped and he turned around. And then he looked at his fellow and he's like, "You give that woman anything she wants."
Okay, so that's a good story, okay? But it's unfortunate that you had to have that.
Right, yeah.
But then I suppose you're just using it to your advantage. You have to like hit back, get on with your day, as opposed to...
Yeah.
And do you think that would happen nowadays with the whole Me Too movement? Is everyone a little bit more cautious or no?
Some people are.
Okay.
Some people are not, right? I have a feeling, knowing that surgeon, he probably wouldn't say that today, right? He probably wouldn't, right?
Cop on.
Yeah. So some people are copping on, right? But I agree. It's unfortunate, but you have to decide for yourself, am I going to let it eat me alive and then just have to remove myself from this profession? Or I like to choose the sassy route and just give it back to them, right? Just kind of... Yeah. Like almost put a mirror on them. You really said that? Well.
Yeah, okay. Fair enough. Yeah, because I suppose they just want to see your reaction, don't they?
All they want is a reaction. A lot of these comments, all men want is a reaction, right?
Yeah, and if you cry, they've got the reaction. Right. They can call you a little crybaby, or if you've got sass, they can tell you, "Oh, that's British. She's fantastic. Let's give her a job."
Exactly. Yeah.
And then in terms, so we've talked about patients, and would you see it from a lot of patients because you are small in stature?
I am small. I am 5 foot nothing.
You do, and you've like for anyone that isn't looking on YouTube, like Becky's just like, she's got gorgeous curly hair. She literally is like Shirley Temple, and like a little, So I say they do see you coming and think you're like,
they do,
a little, probably like a little transition year student that's just like, having a little look around.
Yeah.
So you're just very direct with them.
I'm just very direct. And this is maybe, you're all going to hate me now back in Ireland. I just play the Irish card. I play the Dublin card. I'm like, I'm from Dublin. We're straight talkers, so I'm going to tell you how it is.
Okay.
And usually then people are okay with it, right? Because that's the other thing. They don't expect this like straight talking woman. You're right. They expect some little They
get more than they bargain for, then, don't they? What's elderly care like over in the States then?
Ooh, not great. Again, so they have Medicare. So in some ways, the healthcare is definitely better maybe than for working age adults, because regardless of whether you have a job or not, you do have some health insurance, right? Mm-hmm. But then when it comes to like paying for nursing homes and things, so Medicare, I believe, will cover some of it, but if you have any assets at all, you have to put all those assets into paying before Medicare picks up the tab.
So you have to pay, you have to sell your assets, pay for your care, and then once you have zero in the bank, they come in.
Then they come in.
Christ.
Yeah.
And like, is anyone worried that they'll do that and then Medicare won't come in and look after you? Like,
that's true. That's true. Like I always say, sometimes I say my job is the easy job. The real heroes of the medical system in America are the social workers, because they know all the rules and they help patients navigate all of this.
Okay.
Right.
Okay. Getting back to epilepsy.
Yeah.
can menopause aggravate it, or can epilepsy come on someone in menopause, perimenopause? Well, we've just answered it because you said it does increase at 50 plus kind of thing. It does tend to increase.
It does.
Is it to do with hormones? Do you know?
I honestly, I don't know. I honestly don't know.
Sure, there's such a lack of awareness of menopause in general that, like, maybe, you know, in 20 years' time there might be more research done on this. Yeah.
No, I agree. I personally don't know. I'd have to like look it up. But it's certainly something that people are not talking about. You know what I mean? I will say, just for women out there who are on birth control, oral birth control, and have epilepsy. So we do know that estrogen lowers seizure threshold. So sometimes I'll have a female patient who will start birth control and all of a sudden her seizures are uncontrolled. She's having seizures.
Okay.
Yeah.
And could that so if someone's predisposed to epilepsy and they go on the pill, could that start them off then? Have you see that? Or is
I
it just
haven't seen that.
Okay.
But so I always tell my patients, when you go to your do you call them ops and gynae here? No, what do you call them here?
Women's health doctor.
Women's health, or I guess your GP, whoever's going to
GP.
put you on the pill, always ask them to be on a progesterone predominant birth control, not estrogen.
So then, if you bring that back, if someone goes through menopause and her estrogen levels drop and she's an epileptic, would we see a better outcome then? Less seizures? Or
we probably would.
Such a pharmacist, aren't I?
I know.
Just like, you know, I'm always like, there's a point. I need to find that out.
Yeah. No, I honestly, I don't know.
Okay.
I'm sorry.
Okay. No, that would, it's just
it's
interesting.
good. No, but
thing, though, isn't it?
It's very good. I mean, there is, I just don't know.
Okay.
I'm sorry.
Is it ever possible to fully manage epilepsy, like to fully control it?
Yeah.
It is?
Yeah. Yeah. So you know, like 2/3 of people will be controlled on 2 medications, right?
Mm-hmm.
And then some people, like I said, we do surgery, right? And the data at that, at like 5 years post surgery, about 70% of people are seizure free. Now, the longer you go out, the less people, right, are controlled. But there's a lot of people with epilepsy that are controlled. They just have to keep taking their meds, right?
So you would prescribe medication in the hope that, like, down the line they'd go for surgery, would you? Or would you, are you happy for them to stay on it for lifelong?
I'd be happy for, most of my patients are just on medications.
Okay.
They don't go for surgery, right? And like sometimes, so for the people that are still seizing and surgery isn't an option, we have other options. We have like neurostimulators where we put electrodes in the brain and we stimulate the brain. And actually just a month ago, and this is very like cutting edge, phase 1, the 4th human ever, we implanted stem cells into a young man's hippocampus, and we're going to see if that's going to control his.
Oh my God, are you part of that research?
Yeah. Well, I'm like a site PI. Yeah. So
but still,
it's fun.
So good, isn't it?
No. So that's what
really
I mean.
Cutting
like
edge.
that, and so this is a problem with the American system. It's broken on so many levels, but it's also then these things like come your way. You know what I mean? Where you're like, this is kind of cool. Like this is literally the 4th human ever. So
mad, isn't it?
Yeah.
So someone wants to know about petit mal seizures. What is the difference between them and then the temporal lobe ones?
So petit mal is what we call absence seizures. So
they're the absence ones
that we discussed.
That's great.
Yeah.
Okay.
Yeah.
And then someone wants to know what supplements can you take in if you have that don't interact with epilepsy meds.
So the one that comes straight off is St. John's wort. I don't know if anyone. And then
so St. John's wort is used to treat. Well, people will treat depression with it. However, it isn't available in Ireland for that reason, and it's actually only prescribable in Ireland. And it's an unlicensed medicine. Okay. But I know in Germany and in Europe they use it a lot. They use it a lot. Yeah. And then I would have thought ginkgo biloba.
Yes, that was the one I couldn't remember. Yeah.
And then I'm just. Oh yes. So can we talk a little bit about epilepsy and pregnancy?
Yeah.
So people that are epileptic.
Yes.
And they would be on their medications.
Right.
Should they come off their medications when pregnant?
No.
But what about potential damage to the fetus? How do we navigate that?
So there are so most of the newer anti-seizure meds, right, are not as dangerous as the older ones for the unborn fetus, right? But what is very dangerous for the unborn fetus, if you think about your uterus, it's great big muscle. So if you have a convulsion, your muscles contract and they relax, contract and relax. And you don't want your uterus to also start contracting, relaxing, because the child can actually asphyxiate, they can have a stroke, they can die in utero.
Okay.
So, coming cold turkey off your seizure meds is like the absolute wrong thing to do. Okay. And so usually what we do is we check monthly blood levels, because that's the other thing with the changes in hormones of your seizure medication. Seizure medications interact with estrogen to keep a tight on what's those levels, and we might do doses up or down. Okay. I know a big controversy about Valproic. NHS, right?
Yeah. So that's Epilim. Over, like it's known as Epilim here. But yeah, valproic acid.
Yeah.
So like even it was like a few years ago, but I was well into my career before this started. They started giving out these information leaflets where you had to go out to every patient that you dispensed Epilim to and talk to them about their contraceptive. Yeah. If they were using contraception, if they were a female of childbearing age, because sodium valproate was shown to cause, is it brain damage, Rebecca? Is it like IQ
It's
levels?
IQ, so I think it can lower the IQ by about 10 points.
Okay.
So, yeah. And so I think in America we were much more aware of that for maybe longer, right? So I would just automatically, if I have a young woman of childbearing age, I would not choose that medication unless I really had to, right?
And why would you have to choose it over another one?
So it's very good for what we call generalized epilepsy. It's kind of first choice. But even in a younger woman, I would always choose something else. But if like say lamotrigine didn't work, or levetiracetam didn't work, then I probably would choose the valproic acid, right? But like it has other awful side effects as well, right? Metabolic syndrome and hirsutism, and people gain weight.
Is hairy hair, like where you don't want it, generally your face, your chin, and that. Yeah, and the weight gain too.
The weight gain.
But in your career, did you so when you started out prescribing medicines?
Yes.
Would you have never prescribed sodium valproate to a woman of childbearing age unless it was absolutely necessary? Yeah. So for your whole career,
for my whole career, 15 years?
Yeah. So okay. Yeah, so, but it's interesting that those leaflets have only come. Like, there was always the fact that there was there was always the side effect that people were aware of. However, it was only really a few years ago that we were encouraged to go out and have that conversation with. Now, most people are on contraception and double contraception. You know, they're encouraged to use condoms and everything else. But I think there's a couple of cases now pending in the courts where women, weren't told. They claimed that they weren't told. And their children were born with issues. But I actually can't even comment on them because I don't know the ins and outs of it. And I think it's something
I think it's always, like I always tell my young female patients, like, are you on contraception? And even if you're on like double protection, use a condom. Right?
So that being said, though, someone is pregnant, you put them on medication. There's always potential side effects with medication. How do you square off that if a child is born and there's issues and the mother has been on medication? How is that in terms of you? Where does it leave you liable or?
So as long as I inform her, I don't think I'm liable. Okay. Right. And you have, again, it's this kind of balance of what are you doing, what's overall the best for the mother and the child. And a lot of the effects of these medications in unborn children is like cleft lip. There's some cardiac, some heart defects. And so if we know about them ahead of time, right? So like, for instance, in America, again, we're uber specialized, right? So my epilepsy patients would go see a specialist obstetrician that deals with high risk cases. So she'd probably get a few more ultrasounds and they'd be looking for those, malformations ahead of time so that when the child is born, then they can go, if they need to go to a surgeon or somebody and get it fixed.
They can sort it out.
Yeah, they can sort it out. Okay. So there's nothing I think that is, but women with epilepsy do have more miscarriages. I don't know my head what the numbers are, but I know they have more miscarriages than the normal population.
And is that to do with the fact that they're on the medications, or just the fact to do with the illness?
I don't know if it's the medications or it's the illness.
Okay.
Right. Yeah.
Okay.
Yeah.
Did you see an increase in epilepsy being diagnosed during COVID times, or?
No, not
No.
no, I didn't. Again, I don't know the data around that, but I don't think so. I mean, I definitely had patients who had it.
Yeah. Okay.
Yeah. That, and they were definitely. I had a few that were actually admitted, and they had seizures. Actually, I had one lady who had been controlled for years and then got COVID and then had some seizures. So
okay.
yeah.
Can people grow out of epilepsy? Like if a teenager is diagnosed with it, a mum here is worried and just says it, can you actually grow out of it?
So there are a few childhood epilepsies that you can grow out of, but usually the seizures start like around 5 or 6, and then usually they grow out around 16, 17. So if they've had their first seizure at 15, it's unlikely.
Okay.
Yeah.
And things to avoid in epilepsy apart from alcohol, any illicit drugs,
any illicit drugs. Yeah. No. So what I tell my patients, I tell them it's clean living, it's moderation. So sleep deprivation will lower your seizure threshold. So get a good 8 hours sleep. And I always joke with them, like, I'm Irish, I'm not going to tell you not to drink, but like you can have a glass of wine with dinner. Just don't binge drink, don't drink in excess, right?
Do you know what actually I realised that we just didn't, can you explain what lowering a seizure threshold means, because people may not understand what that means.
So it just makes your brain more likely to seize, right? So it will change the makeup of that chemistry, that chemical stew up there, that it's more likely that these neurons will just start firing and you'll have a seizure. Yeah.
Okay. Yeah. You can go back to answering question and answer.
So what we said, sleep deprivation, alcohol, high fevers, right? So if you have epilepsy and you have a high fever, take your acetaminophen, your paracetamol, get that fever down quickly. That's another thing. Yeah, it really is. It's obviously no illicit drugs, right?
But people do the illicit drugs.
They do the illicit drugs.
Do you see more seizures as a result of that, or?
No, I mean, I haven't. I mean, I have one. I can think of one young man that every time he takes synthetic I can never say it, cannabis.
Cannabinoids.
Like, cannabinoids. He has a seizure. So I tell him, stop doing
the synthetic one. Here's some natural grass. Is that what you do?
I don't actually give him the natural. I'm
and you open up the drawer. Well, those synthetic cannabis is a league of its own. Like the mild stuff that's grown naturally.
Right. Yeah.
And it's not as potent as some of the stuff that they're making.
No, it's crazy.
Unbelievable.
Yeah, no.
Unbelievable effects on people's psyche.
Yes.
And that's where the worry is with all of this legalization.
Yeah. No, I agree. I think in 10, 15 years we're going to realize that weed is not as innocuous as we think it is. I'm not trying to be a fudgy-dudgy. I just don't think we have the data there, right? To say that it is innocuous. I also think there's a lot of people that self-medicate with it. So, people with anxiety and depression who are like smoking every day. Yeah. I talk to them. I'm like, are you sure? Don't you want, I prefer to put you on like an SSRI, like an antidepressant, right? That we know the side effects, we know the long-term outcome, than, smoking a joint or two every day, where you're just high and you can't feel, you can't think, you can't work through what
your emotions.
Your
and
emotions,
like that too.
Yeah.
So is it legalized in your state?
So in Illinois it is.
Okay.
Yes. Yeah.
And you kind of would be hesitant or worry somewhat about the data that's going to come out in 10, 15 years time about the amount of it. I saw something in the newspapers there recently. Apparently there has been an increase in postal deliveries of cannabis since the states have legalized it in some areas, because people are just posting over here. Say the postman and Unpost are having a great old time seizing it.
There you go, seizing it. Like,
one for the Gardaí and one for me. But yeah, I always find the conversation in and around the legalization of any illicit substance interesting, because first and foremost, if something is legalized and standardized, you know what you're taking.
That is fair. That is fair.
But then there's also the thing of, if it's legalized, then you've kids that are not going to be, they're not supposed to use it until they're 21, but they're going to because it's legalized. And
right.
They, like alcohol over here.
Yeah, exactly. Yeah.
I think it's so nuanced, and I love talking about it, but I still can never really draw very many conclusions.
No.
You know, because even if it, just say it was legalized here and standardized and everything, and it was only available for 23 and up, because we know that's when, you know, our brains have developed.
Yes.
There's still going to be kids that think it's okay to smoke it, and then some of those kids may be more predisposed to, say, psychiatric illness.
Absolutely.
And then the issues that come with that.
Right.
Then are we being a mother state then by doing that? I have so many questions in my head. I need like roundtable discussions
I think
ad nauseum for this. I have so many thoughts, and I can't draw a conclusion to anything. I'm very open-minded though when it comes to anything like this.
Right.
And I think that there needs to be all the stakeholders involved.
Right.
To really give the best kind of.
No, I mean, I think you're like, I absolutely agree, right? I think, but I think in general, when we turn to a substance, whether it be a cigarette, a pint, you know,
a
LSD. Joint, LSD, there's
cocaine.
Something else going on.
Yeah.
Right. And I think, I don't know, the legalization.
I agree though, there's a lot of self-medication, and
right.
I don't know what the mental health services are like over in your part of the world, but they're pretty dismal here.
And they're pretty dismal. There's like the huge shortage.
Yeah. And particularly with childhood mental health services.
Right. Yeah.
And the reality is if a kid is not picked up on quickly and there isn't intervention, that child can go on to abuse.
Right.
And that's just the self-medicating, isn't it? And
then
absolutely. That brings
absolutely.
in
and then
itself
it's exactly.
A vicious circle of
it
kind of
really
like
is.
Self-medication, acting out, all of the things that come with that.
Yeah.
That's a podcast for another day. I want to go back to my notes, Becky.
Okay.
So, Becky.
Yes.
Let's talk about the fact that, so we know you're a doctor. We know you're a mother of two boys.
Of 2 boys.
So you're also divorced.
Yes, I am. Yeah.
Why? Why? Tell me why. And how has it been for you being a divorced mum? It's tricky, I'd say, yeah?
It's tricky. And so like I'm not here to bash him, and I'm not going to do that, right? I think but it is one decision in my life I have not regretted.
Okay.
And it's been tough though. I think that whole process. So I think there's like multiple phases to it. So I think ultimately what happened in the marriage was I became the default parent, right? And I think there's a lot of mums out there who, you know, work full time and have kids and do everything for the kids, right? Whether it be, you know, the washing, the cooking, the organizing, the activities, the getting them to school, like everything. And if I'm honest, I just started becoming bitter, right? I was just kind of angry. I was like, you're not pulling your weight. Like, I need help, you know? And so I think that's ultimately kind of why the marriage failed, right? Okay. And I think definitely the pandemic sped things up.
I think it sped up a lot of divorces and separations, etc.
Yeah, that it became very apparent. I was not happy. I did not want to share the same 4 walls, right? Okay.
Did you try counselling or anything like that before?
So we did. So we tried counselling. We went to a couples therapist, and there really was no insight. Okay. And so I think you in your mind, you make the decision that you're going to get divorced a long time before you actually do it, right?
So that I want to ask you, before, had you made that decision before you even went for therapy? Did you think, I'm 90% checked out here?
Yeah.
Okay.
Yeah.
Okay.
And like we did it for 6 months.
Okay.
So I don't think anyone can say I didn't try, right?
Mm.
But I do think to that point, when I went to do it, I'm like, okay, well, I'm going to do this, and then nobody can say if we get divorced, I didn't try. Okay. So it was, no. And then you something really dumb happens and you're like, and that's it, I'm done.
Like they literally don't pick up their socks. You're like, right,
yeah,
that was the straw that broke the camel's back, sir.
Yeah, no, it's like, it's always, it was something completely inane, right? That, and so then, immediately after, there's kind of I'm just going to say, I'm like, oh shit, right? Like, what did I do, right? And then comes the relief. And then you're like, oh crap, now I actually have to go through with it, right? And then there's the whole, custody and separation and so in Illinois where I live, you have to be separated for 6 months before you can file.
Oh my God, people listening to that are going to absolutely like, that would be the dream here.
Really? How long is it here?
Do you know what? I think it's either 3 years or it could be 5 years. It's mental.
Yeah, no, I don't think I could do that.
Yeah.
And then in Illinois, then the marital assets are just kind of split down the middle. Okay. So the really hard part was negotiating the custody of the boys.
Yeah.
Right? That was, and so I'm going to say this, I'm coming from a place of extreme privilege, right? I have a job, a well-paying job, right? So I knew in leaving this marriage, I didn't need him for anything. I could go this alone. Like financially, I could go this alone.
You see, a lot of women can't say that.
Yeah, no. And so that's where I know I'm very, very lucky, right? And so, he didn't want to leave the house. And so I ended up leaving and buying my own house. And then there was just all this negotiation around the boys. That was really the hardest part, right? And like I learned, your lawyer, your solicitor is not your therapist, right? So, so
I did have a solicitor on here. She's an absolutely gorgeous lady, and she did, she says, you can get so sucked in by people, as in like sucked into their life by the sorry stories.
Yeah,
and it's tough to kind of like.
No,
but you have to, because otherwise they'll be there for hours with you. They'll be charging you a fortune too.
Well, that was the thing. My lawyer was just charging me
for your moaning,
for my moaning. Like he would do something, and I'd be so mad, and I'd like pick up the phone. Can you believe he did blah blah blah?
And he's like, okay,
timer on, literally, and then like I get a bill for like $500 or something.
I just phoned you for a 5-minute rant.
Right.
What the hell?
Exactly. Okay. So I did. So then I put myself in therapy as well. I was like, okay, I'll save those rants for the therapist, and the solicitor, the lawyer for just,
And is there an idea of reckoning them when you do the therapy yourself, where you kind of go, the two of us were in this marriage, I allowed it to happen type thing, and you have to, you can't just blame the other person either, is there? Yeah.
No, I mean, it takes two to make a marriage, it takes two to dissolve a marriage, right? Or to end a marriage, right? And so, and so then you go through this phase of, you kind of mourn the relationship, right? Because we were married for 11 years. So I was like part of this unit. Now, it didn't matter that I wasn't happy, but when I moved through the world, I was part of a unit, right? And now all of a sudden I'm part of a different unit. It's kind of like, it's me. And then it's me on my own when I don't have my boys. And when I have my boys, I'm part of a unit again. Yeah. So so you mourn that. And I think you also mourn the life that you didn't get to have.
Yeah.
Right?
Yeah.
So there's kind of a loss. It's so weird. You go from angry, I can't stand this person, I need to get out of this situation, to kind of relief, to kind of mourning what just happened. All the time while you're trying to like manage your children's emotions as well and help them through it. And
how were they?
They are now good. They are now good.
Was it tough though for them?
It was tough. It was, I think my little guy, he was only 2, so he didn't really. But my older guy, he was older. He was 8, and so it was tough on him.
Yeah.
And that's the other thing, like you don't want to get them caught in the middle, right? Mm-hmm. So
would you say you're good co-parents? Are you friend. No,
We're working on it.
She's making faces. She's making faces for anyone listening. She made a grimace. She's actually an excellent actress, and I think that you should have gone into acting, Becky. Bit of acting on the side, bit of neurology.
There you
neurology
go.
on a Monday and a bit of acting on a Tuesday.
There
so
you
you're
go.
working through it. So
We're
it's
working
tough,
through
yeah?
it. It's tough, right? And I think. Yeah, I think once we got into kind of our routine with the boys, I think things then got exponentially then better.
And how is the routine with the boys? How does it work? Is it like 50-50 or what?
It's 50-50, and because of their ages, they're with their dad Monday, Tuesday, they're with me Wednesday, Thursday, and then we swap the weekends. So I live relatively close to where they do, so it's not a huge, because it's a lot on the boys to be going backwards and forwards.
Do they just have double clothes everywhere, so they're not bringing suitcases back and forth?
Yeah, no, they have double clothes.
Okay.
Yeah, even my little guy who started kindergarten had to like talk about himself, like introduce himself. And he was like, and I have 2 cats. I have one in each house. And I have 2 sets of toys in each house.
Okay. Fair enough.
Yeah.
But they can be quite resilient. So what they learn and what they are used to, they're used to.
Right.
And I think so long as there's a respectful talking about the other parent.
I agree.
And has that kind of worked for
and
you
that has
thus
worked.
far?
That has worked. And I think if you're happy, they will be happy, right? I'm the mum of 2 boys, and so it was important for me that they did not grow up thinking what my marriage was what it should be, because I did the cleaning, the cooking, I did everything, right? And I worked full time, right? And so, now they see, right?
Okay.
They're like, because now they see their father, like.
Did the father have to move his mother in?
I mean, I'm sure that was thought of. I remember I got them, they came back to me and they had been visiting an aunt, like a sister of his who lives like 4 hours away by car. And he had packed clothes for the little one and forgot to pack clothes for the older one.
Oh, goodness.
So it was kind of a little bit of vindication. And literally like, okay, yeah, no, I did do everything, and so, yeah.
And what's it like then only having them? That sounds pejorative, but
no, but it is.
You have them half time. So
right.
It's like those touch points on the days that you don't have them. Do you talk to them, or is it just like they're with their dad? There's no need.
No, they're with their dads. Like they can always call me, but I don't call them, right?
Okay.
Because I also think as much as I miss them, right? It's his time with them. I don't want to encroach on his time.
Okay.
Because when they're with me, I'm sure he misses them too.
Yeah.
So it's kind of trying. At least I try to be like respectful, of the time. But they're always welcome to call me, and sometimes they do.
Of course.
And then I worry, like, what is going on over there that they need to talk
just
to me.
before we came into the studio here, Becky was like. She's like, can I get your Wi-Fi? Because she's only in Ireland a couple of days, and she was you were texting your childminder. And she's like, I'm literally trying to find, like, I'm literally, sorting out childcare like half across the Atlantic. So you're never not a mum.
You're never.
It's always worrying and thinking about things.
Yes,
isn't it?
always, right? But then, and so that's kind of like almost like the plus side of, so, if you're in the thick of a marriage and you're doing everything and you've got kids and a career and everything, and now you've got time on your own, right?
So do you spend that on Tinder?
I mean, I used to.
Oh! How many dating apps did you download in those early days, you hoe?
Oh man, I mean, a few, that's all I'm going to say.
Okay.
But but you do, like, all of a sudden, and I mean, I'm sure you and your boys are now older, but like mine were still kind of little, like, where in the morning they were getting in and having a shower with me. Like, how many mums are like, I just want to have a shower on my own?
I know,
right?
I know.
So that was like a nice thing. But then what happens is your circle of friends change, right?
And how does that happen?
So some of it happens, so I think, so again, when you're running up to, you've kind of made up your mind you want to divorce, but you haven't pulled the trigger. And I had a lot of female friends who were full-time career and full-time moms, and they were very, very supportive. And then as soon as I pulled the trigger, like a lot of them changed.
Why?
And so I think there's
Did they think you wanted to steal their husband?
I mean, if you
sorry.
saw them,
You're like,
if you saw their husbands, like,
no,
no.
sorry. But why do you think it changes?
So I think some of it is that I think some women are just worried, like, now you're this like free and loose woman, you're going to come after their man.
God.
But I think a lot
They should
of
be so
them
lucky to get off your hands. Anyway, we'll move on.
But I think some of it is also you've done something that maybe they don't have the guts to do.
Like you're holding a mirror up to them or something?
You're kind of holding a mirror up. You're like, you know what? Because and when I look back now, the women that really kind of turned their back on me, and I mean, they turned their back while they were like sticking a knife in me and being very mean and saying nasty things, very judgmental. I think they're just very unhappy in their own marriage. And so, you know, if you're presented with someone who you know was just as unhappy as you are and decided to get out, what's stopping you?
Okay.
Right? So it's kind of...
So those are psychological things going on there, isn't there? Like
there's always...
really drum that down. And I suppose, you know, there's loads, I don't know, there's loads of memes that go around and stuff like that. But I suppose if someone is actually showing you hate or like not being nice, like you do have to think like what's going on in their lives to make them be
usually
that way.
not about you.
No.
Right? It's usually more about them.
But did you find that difficult then?
Yeah.
Because obviously you had these ladies that were friends.
Friends. And now all of a sudden...
What is it? They're just not picking up your phone calls or they're just...
They're picking up my phone calls, but they'll like pass comments, right? Like just like, you know, like I had one... like I was like, why don't we go out? Let's go out for a drink after work. And she was like, well, I have a family to take care of.
Oh, so nasty.
Yeah. I had, and even professionally, I had another woman tell me that I should stop dating men and start dating my promotion, my academic promotion. And that was a woman.
Academic promotion won't be giving you the D.
No, it will not. No, it will certainly will not keep me warm at night. No.
But you find someone on Tinder, didn't you?
I did.
A lovely person.
A lovely man. Yeah, he's great.
Yeah.
No, he's...
So it can happen. And it's not just necessarily a hookup place, is it?
No, I mean, there's definitely people that are there just for hookups, right? And then, but there's like all sorts. And like, it's so funny because you're talking about like other apps, like you go onto other apps and you find the same people. So it really, it's like...
I have friends that are single and they're like, oh my goodness, I keep like this person keeps popping up and I've already dated them. You know, it's like, God, how do you...
Yeah, no, it's like enough. Okay. So and that's like the other thing, right? So it's like, I feel like my friend circle has changed, right? Because a lot of my friends have families, so it's not like they can go out, you know, on a Tuesday night, say for a drink, because I don't have kids, but they have kids and homework and whatever. So now I have a lot of like non-children or friends with no children.
Okay.
So your friend group also changes, right? Because they have time when you have time. Right.
I'd say you've loads more gay friends, do you?
I do.
And they know how to party as well, which is
great.
Great.
They do. And they know the best restaurants and
Okay.
No, so it's a lot of fun, right?
Yeah, so I think you just need to change your perspective and go, look, okay, so maybe these people were meant to be in my life when I was going through this.
Right.
And now that it's gone, they're not in my life anymore, but I'm an outgoing person. I can find new friends.
Exactly.
But it's good. I think this is a nice... honest talk about it, and it's not you know, you're not blaming or shaming, but it's just like this is kind of what happens.
But this is what happens. It's funny because and she's now one of my best friends, also divorced, and she kind of, when she heard I got divorced, she reached out to me and she kind of sat down and kind of had this chat that we're having now with me. And she's like, and I remember at the time being like, no, my friends are good. No, I know my friends. They're not going to turn their back on me. And they did, just like she said. Right. So it does happen. And I'm going to say this, and this is, I love to everybody, but married women are the meanest to divorced women. They say the meanest things.
Oh my goodness.
Yeah.
That's sad though, isn't it? But
It's sad.
Does that bring back the whole thing about, you know, women not helping each other or collaborating or, you know, like some of my best allies and that have helped me so much have been women. But, you know, I think that sometimes we can be very hard on each other.
Very, very hard.
And
very,
quite
very
judgmental.
Hard. Yeah, I think if you don't fit in a mold, you make people nervous. And people are usually not their best selves when they're nervous either. You know?
This is true, but they've done studies on women where they've actually, you know, attached those things that you attach to people's brains.
Yeah.
And like brain activity just goes nuts when like they're gossiping.
Really?
Like they just get so excited. Like it's like flashy, flashy, flashy. Whereas blokes don't.
They don't.
So we're obviously, it must be evolutionary.
Yes.
We're wired to maybe see other women as a threat. I don't know. Maybe it's because we need to be protective of, we wanted the person that was going out and getting the meat when we were Stone Age to come back to us to feed our children, not someone else's. So I'd say there's loads of reasons for it.
Absolutely.
You know? But I think that definitely we all need to, and everyone, you know, if there's just a little bit more kindness in the world and a little bit more forgiving.
Just forgiving and just like live and let live. You know what I mean? I think that's,
totally agree. So would you, you know, just asking for a friend here. So would you recommend Tinder then?
I mean, Tinder's fun. I mean, Tinder is,
I have, I know a girl who, like, she was like, right, I am 34 and I need to find someone, and you know, I need to find someone good because I need to have a couple of babies. So she took it, like this was a second job, right? Wow. So she actually went on before lunch coffees. So she'd, you know, meet someone before work. So meet someone at 8 o'clock for like a little, you know, coffee before work. Then she'd meet someone on her lunch break. Then she'd meet someone after work. Wow. Then she'd go back and get changed and go out for a drink then. So she could have 4 dates.
That's exhausting.
Because she basically took the attitude like, I'm probably going to have to kiss a lot of frogs or meet a lot of people before I meet the one. And you know what? She did it.
Oh,
but
good for her.
But that is a career in dating, isn't it?
That's exhausting. You see, that's where I think I'm in a different position, right? Because I have my kids, I have my career, right? So when I'm dating or I'm going out there, pushing myself out there on Tinder, I'm not, my mission is not to get married and, you know, have kids in a house and all the thing.
Yeah.
Right? That was me back in my 20s. And I probably if I'm honest, probably shouldn't have married him, but had that pressure on myself, and it was like, well, he's not that, you know what I mean?
Well, our body clocks are just, you know, they're not designed for modern living, are they?
No.
I think our body clocks should start late.
Absolutely, yeah.
You know, periods at 20, and then go on a bit later as well.
Yeah, exactly.
Because we're all living longer.
We are.
But unfortunately, that isn't the way it happens. So so I agree with you. Some women get married because
they feel this pressure, right? And so it's kind of freeing, like now, 43 dating, it's like I'm just doing it for fun, right? It's just like I can find someone for me. I don't have to worry, you know, has he got a good job? Is he going to be, you know? Now, obviously, he's lovely with my boys, and if my boys didn't like him, like that would be a game changer, right? But beyond that, you know what I mean? So it takes a lot of pressure off of it.
It does, actually. And, you know, for people out there that are, you know, like what you say, you don't need to find someone to bring anything to your life other than a nice cuddle, nice company, you know, and someone that you can share your life with, as opposed to feeling under pressure to find someone to settle down with, to have babies with, which is
a completely different.
And women are in a terrible position in that way.
Absolutely.
But I have a friend who says he dates a lot and he uses the same lines all the time. He uses the same stories in his head that he uses, you know, to make the chicks laugh and stuff. But I suppose it would get repetitive, depending, you know, if you're seeing the same people
over the time.
I'm sure that girl that had a script in her head too, because there's only so much you can talk about.
There's only so much, I think. Well, and that's the thing, like I remember, like I went on a couple of dates with a guy who in my 20s, I would have thought he was like the best thing since sliced pan. I'd be like I want to be with him, right? And it's funny because you now meet that person in middle age, right? And like after a couple of days, I'm like, nah. This wouldn't have worked out in our 20s and it's not going to work out now. You know what I mean? So you kind of, it's not like you're going back to dating with zero, you know, from zero. You're just coming at it from a different angle.
And what about the ghosting that's done as well? You hear about this where you put a lot of effort into, say, texting people. And then they just go off the radar.
And then they go off. So that a lot, well, at least in my case, a lot of that would happen on Tinder. So, you know, there's a chat part of like the Tinder app, right? So you would chat backwards and forwards, and that was always stressful because I'm always like, was that funny? Does that come across? You know, or is he gonna read the double entendre there, or you're like, ooh,
or is he thick?
Right, exactly. But that can go on. Like that can go on for days. That can go on for like. I remember I have one girlfriend who was literally doing this for like 2 weeks, and I'm like, what are you doing? He's never gonna ask you out. Like, so I said to myself, like when I was on Tinder, okay, if he hasn't asked me out within 48 hours, I'm ghosting him. We're done. Because a lot of people will be having multiple conversations with multiple people, right? So they keep you warm until maybe they get rejected by someone else. And then you might be there filling. Do you know what I mean?
It's a real numbers game.
Yeah, it is.
And
it's like a video game.
Yeah, and it also makes people feel quite disposable, doesn't it? Because it's like this whole swiping. Yeah. What do? Do you swipe left or right?
I think it's right. It's right. Yeah.
Right, if you like them.
If you like them.
Okay.
Yeah.
So it does make it... Yeah. Like people are disposable, and you're showing your best self in those pictures,
right? Yeah,
or some people don't.
Well, no, some people. I've got catfished too.
Okay, and then also you said some fella had like his fifth picture in was like a picture of his willy.
That's right.
Like, how do they think that people want to see that?
I
think it's a titillation thing. I actually think that they think, right, out of 100 women that might see that, one person might actually think that's funny and like it or something.
I think it goes back to what we were talking about, a reaction. Yeah. Often men just want a reaction, right? Like asking me about my sex life, or putting a picture of their erect penis, like great. You know what I mean? Like I think some of it is, you're right, it's like titillation and just looking for attention.
And I've spoken to loads of women, like friends of mine that will be dating, and men send them like those pictures, but also send them pictures of themselves jerking off. Or like,
I haven't got that one, thank God. I don't want to see that.
Well, you certainly don't want to see it like before you've even met them.
Right.
Oh, I think I need to do a podcast with someone who is like really familiar with this, and like we can have a serious banter with it, because
absolutely,
there's loads,
absolutely. There's so much, but like, yeah, there is. There's so much of that.
I'm going back into the questions about epilepsy now, just to make sure that I didn't miss anything. Doctors misdiagnosing epilepsy with FND. What's that?
Functional neurologic disorder.
Okay.
So this was like my lady who thought I should work in a nail salon. So some people have what we call psychogenic non-epileptic spells. Okay. And so on the outside they look like seizures, but when we have the person hooked up to the EEG, to the brain waves, their brain waves are absolutely normal.
So how does it happen? So
I think, and it's kind of on this spectrum of like conversion disorders in psychiatry, right? Okay. And so it's often somebody, my understanding or how I try to explain it is usually somebody has a very deep rooted kind of conflict that they haven't worked through, psychologically. And it kind of like their subconscious kind of comes up and hijacks their body. Okay. And so it looks like a seizure, but it's not. And so like there is there's cognitive behavioral therapy that you can do. Okay. And so people, I think when people understand kind of what that conflict is and work through it and identify triggers, they can stop having those spells. Okay. Yeah. And then I think we'll just go for one last one here in this. My son has refractory epilepsy since 13. He's 25 now, and I've lost hope of ever having control of the seizures. What's refractory epilepsy? So that's when he's still seizing and he's been on at least 2 anti-seizure medications. Okay. So there, I mean, I can say this from kind of an American standpoint, right? Yeah. There is hope. There's lots we can do. And so I don't know if it's if he's ready for surgery. I do believe they do epilepsy surgery in Beaumont. Oh yeah, they do. Yeah, I've had patients of mine that have had really good outcomes from it. But also, like I said, if he's not a surgical candidate, there's neurostimulation that we can do. There's I saw someone ask about the ketogenic diet. Yeah. Right. That's actually very good. Okay. Yeah, so it's worth trying. So explain how that's good. So the ketogenic diet, basically it's high fat, high protein, so no carbs. And the idea is that you put your whole body into ketosis. And this makes it harder for those neurons to start firing.
Okay.
Now it's hard to stay on the ketogenic diet, right? But I have some patients that do it, and it's some medication and the ketogenic diet, and they're seizure free.
Wow! And is there like have they done studies on this as well?
Oh yeah, they've done studies in this. Yeah.
And that's just purely diet.
Purely diet. Yeah.
And then is there anything else? So, but then you were saying like good sleep, exercise, diet. Like there's nothing really else other than the medication and going to see a neurologist that people can do, is there?
Yeah, no, that's it.
Okay.
Yeah.
Is there a relationship between epilepsy and lower IQ or learning difficulties or?
So there is a relationship. I think, often, so a lot of people with intellectual disabilities will also have epilepsy, and it could be, if they had a stroke in the womb or around, if they have cerebral palsy, right? So usually whatever caused their cerebral palsy also is kind of the cause of their seizures. Okay. And then there is also people with bad epilepsy who have years and years of seizures, their memory will slowly decline.
Okay.
Yeah.
Okay.
Yeah.
We've covered loads.
We have.
I love the way we went straight from Tinder right back into
epilepsy.
Just to bring it right full circle. Okay. And now we're at the end, I think, of the podcast. Is there anything else you'd like to say?
Just thank you. And
it's been great.
Yeah.
But I have to ask you 2 questions.
Yes.
So, Assistant Professor Rebecca O'Dwyer, former past pupil of Muckross, Berlin, and Illinois and everything else, Chicago and everywhere else you've been. What advice would you give young people today?
Stick to your gut.
Okay.
Right. Just listen to your gut. Right. Like if I'd let the Leaving Cert define me, I wouldn't be here today. Okay. So yeah, just stick to your gut. Just have faith in yourself and don't be afraid to fail.
Oh my goodness. Like there words, I think you just took them out of my mouth. Absolutely. You just got to do it, don't you?
You just got to do it.
You're never going to regret trying something. And if you fail miserably, it's so fucking what?
It's so what? You'll learn something from it. That's the thing, right? Mm-hmm. Yeah. Like all the times I've fallen flat on my face. Like, and you just pick yourself up.
Yeah, exactly. And what's the meaning of life?
Oh man. What's the meaning of life? I think, this is going to sound really hokey and corny. I think it's love.
Doesn't sound that way at all.
Oh man, what's that song with David Bowie and Freddie Mercury and the end?
It's not all you need is love. No, that's the Beatles.
No. Can I look it up quickly?
Do.
Can
Absolutely,
I? Okay, because it's the bit.
You have all the time in the world.
Shit, sorry. No, it's the bit that David Bowie. Oh yeah. Okay. Yeah.
Yeah.
So it's because love's such an old-fashioned word, and love dares you to care for the people on the edge of the night, and love dares you to change our way of caring about ourselves.
Oh,
that's
it is.
That's love. That's life.
Absolutely. Rebecca, it's been an absolute pleasure. I'm so glad we got to do this. I'm definitely going to Chicago.
Oh yes, without the boys.
Without the boys or the man.
Or the man.
Thank you everyone for listening. We'll catch you later.
Thank you.